morning, friends. Today our guest speaker is Dr. Rakhi Kar from JIPMA, Puducherry. She will be lecturing on myeloid neoplasms with striking erythroid hyperplasia, a case-based approach. This webinar is brought to you by Mumbai Hematology Group, supported by NATCO Oncology and managed by Perfect Square. I thank Mr. James Raja Kumar and the team from NATCO, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our chief guest today, Dr. Prashant Ganeshan from Puducherry, our guest speaker, Dr. Rakhi Kar, all our discussants who are themselves very eminent hematopathologists or some are clinical hematologists, and you participants for sparing your Sunday morning from India and Sunday afternoon, evening, or even Saturday night, maybe from some part of the world. We have a very active website, mhgindia.com. Many of you have been asking that you do not get any information about these webinars or other academic activity. All this is put up at the website and there is no password. So just keep this in your diary, mhgindia.com. It's updated almost every week and you have the details of both past activity and the future activities. Simple to remember, Mumbai Hematology Group, that is mhgindia.com. To introduce you to the next weekend activities, Friday at 7:15 p.m., we have a discussion on what was new at European Hematology Association meeting, the 27th meeting, which was held 2 weeks ago, and the ASCO, which was held 3 weeks ago, in the field of chronic lymphocytic leukemia. Next day, on Saturday, Dr. Varsha Banerjee was to speak on chronic lymphocytic leukemia, but in view of this Friday, best of ASCO and EHA on CLL, we are changing this meeting and we will soon inform you by tomorrow what will be the activity on Saturday. On Sunday, we have Dr. Nikita Mehra from Cancer Institute, Chennai, speaking to us on plasma cell leukemia, the molecular pathogenesis, treatment and recent advances, and that's at 11:30 a.m. And then from Monday to Sunday, 1 week long, we have the best of EHA, which is 3 hours activity daily with 3 guest lectures. In all, 21 lectures, all international speakers, champions in their field who will be covering what was new in EHA 2022. And this will be from 6:30 p.m. to 9:30 p.m. Each talk of 40 minutes followed by 20 minutes discussion, 3 daily for 21 sessions. So you have got a very busy schedule available to you from coming Friday for almost 10 days. So be with us whenever you can. Our discussions today, once again, we have galaxy of very, very important and senior personalities together with some youngsters. Dr. Amrita Saraf from Gangaram Hospital, New Delhi. Dr. Ankur Ahuja from RNR Army Hospital, New Delhi. Dr. Akshaya Mandolya Goyal from TMC, Kolkata. Dr. Vijita Datta from ESI PGI MSR, Kolkata. Dr. Chitra Madiwale from PD Hinduja Hospital, Mumbai. Dr. Jasmita Das from AIMS, New Delhi. Dr. Parimal Sarda from Vedanta, Ahmedabad. Dr. Rama Hariharan from AIMS, New Delhi. Colonel Dr. S. Venkateshan from AFMC, Pune. Dr. Sandeep Sheth from Jhadas Hospital, Ahmedabad. Dr. Sanjeev Gupta from AIMS, Delhi. Dr. Sindhura Lakshmi from Kasturba Medical College, Manipal. Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Subhajit Hajra from AIMS, Rishikesh. Dr. Tara Roshni Paul from Nizams, Hyderabad. Dr. Tushar Sehgal from AIMS, New Delhi. Dr. Udyan Kachi from Vadodara, Udyan's lab. And Dr. Vidisha Mahajan from PD Hinduja, Mumbai. It's time to introduce our chief guest for the day who is going to inaugurate our webinar. And he is not a new personality. He has been our faculty at number of occasions. All of you know him extremely well. We are privileged today to have him to inaugurate our today's webinar. That's Dr. Prashant Ganesh. He's additional professor and head Department of Medical Oncology at the prestigious JIPMER, Puducherry. After finishing UG and PG training from JIPMER itself, he completed DM in Medical Oncology Fellowship training at AIIMS, New Delhi, where he was awarded as the best student in the course. With a keen interest in teaching, he pursued the academic career. He joined Cancer Institute, Adyar, in 2010. He was actively involved in the training of DM students and helped in the expansion and evolution of the training program at that institute. He has received training in bone marrow transplantation, phase 1 clinical trials at the University of Texas MD Anderson Cancer Center in 2012. He has special interest in hematological malignancies, ovarian malignancies, and supportive care. He has been an investigator in several oncology clinical trials and has served as member of various research and ethical committees. He is the lead investigator of Network of Oncology Clinical Trials India, which is a multi-center effort to conduct collaborative clinical trials and is supported by a grant from National Biopharma Mission. I request my friend Dr. Prashant Ganeshan to inaugurate our today's webinar and give some words of wisdom. Remind you, our website is mhgindia.com. If you don't get any information, just go there and you have it. Thank you.
Thank you very much, Dr. M.J. Agarwal, sir. It's been a very kind introduction. Good morning, everyone. I've been working with patients with hemato-oncology almost exclusively when I was in Adyar, and of course, more in the last 4 years since I've been in JIPMER, so last 12 years. I must say that it has been a very rewarding experience. Apart from the fact that hemonc is the one specialty where a medical oncologist can function as a primary treating physician for the most part, as most of these conditions are treated and often cured with only systemic therapy agents. So it is definitely very satisfying to see the leukemia getting cured or the lymphoma getting melted away by the chemotherapy regimens that we use. As in all oncology, I think the last 20 years has seen an explosion of knowledge and very rapid translation of basic research to drugs, which work fantastically in the clinic. And there had been a stagnation, I would say, in the field of new chemotoxics developments, probably in the 1990s. But what has happened in the last 2 decades that this has been replaced by really an explosion in development of targeted therapies and now more recently immune therapy in the last 10, 20 years. Now we are talking about and actually achieving, reaching a goal of chemotherapy-free treatments for many cancers, and it's already been realized in the case of certain types of chronic lymphomas, chronic lymphocytic leukemia, myeloma, and even acute promyelocytic leukemia, where you have these regimens where you can actually not do chemotherapy at all and get fantastic cure rates. So even the cancers like 10 years back where we had the most dismal prognosis, like relapsed acute lymphoblastic leukemia, relapsed diffuse large B-cell lymphoma, now with CAR T-cell therapy, BiTE antibodies, there is a profound impact. So everywhere there are gains and we are getting better at it every day. So it's been a wonderful journey, even though my journey itself is probably a decade or so. So it's very exciting, and I'm looking forward to what will happen in the next few years in this field. Despite all these advances, of course, challenges are there. That, in a sense, is what makes the practice of hemonc so exciting at this point of time. There is so much to do, so much to improve. And each day we have new insights in biology, and more we understand the complexities, the more we wonder at how much we all have to learn. And there's this constant need to learn, relearn, repeatedly update ourselves. This is common to all branches of medicine, but the impact is much more in hemonc. That's what I feel. So this is what I have to say to all the youngsters out there who've already taken up hemonc or contemplating a career in the field. I can confidently say this. You take this specialty, there will never be a boring day at work. Whether you work for 5, 10, or 30 years, there's always a new challenge waiting for you day in and day out. I thank Dr. M.B. Agarwal, sir, a guru par excellence. It's amazing his untiring efforts to get the latest updates in the field to all these practitioners in India. This has been going on for many years. I don't know, sir, how you can get this energy and this amazing, the zeal to bring out these wonderful education topics. The speakers, they're always excellent. And plus added to that, his insightful comments. I've had multiple immense learning experiences by attending these meetings. So once again, I thank Dr. M. Agrawal sir for this opportunity to interact with all the youngsters. And my regards to you, sir, for being so convinced and committed to teaching of this fantastic subject. Looking forward to today's talk from Dr. Raki, who's my colleague in Chipmunk. Once again, I thank you very much and best wishes to all the young students up there who want to take up the field. Thank you, sir.
Thank you, Dr. Prashant, for those kind words, sparing your time this morning and to be with us when your colleague is a speaker for the day. Learning, relearning, not a single boring day, but some of the very, very important statements that you made. One thing that I fully agree with you, that this is a field where there is nothing boring. Every minute you can find something new. Just go and update yourself, and there is just no end to it. The 24 hours fall short. And that's the experience for last so many decades. So thank you once again being with us. And we'll move on with this webinar now. And the next activity we have is the Sunday quiz. So just be ready, you know the system, that something will be asked. You have to find out the answer. You have to email that answer. The one who is first is the winner. And we will tell you the names of all those who are given the correct answer. So today's quiz will show you a picture. And in that picture, there is a blank. You have to fill the blank. And whatever you are going to write in that blank, you have to send that answer by email to mbagarwal1@gmail.com. So you will see a picture. There's something blank where question mark is put. What should be there in place of that question mark? Just that word you have to give as your answer by email. And that's the picture. And I don't have to say anything. You have a red box here with a question mark. What should be the appropriate word in that question?
The shutter button.
So just send that.
The shutter button. Search.
Just send that by email. I'll keep this on for a few seconds. Okay. So send your reply to mbagarwal1@gmail.com. Once again, remember, we have this website that gives you all the details of our academic activity, mhgindia.com. We come to our weekly case profile. And this is a fascinating case. And those who are clinical hematologists will enjoy it. 69-year-old male, 69 today in 2022. 12 years history of refractory primary acquired pure red cell aplasia, receiving various modalities of treatment. So from the age of 57 to 69. Various modalities, the treatment failed. And finally, he had rapid and sustained response to a very unusual treatment. And that's the story for the day. So he first presented in 2010, 12 years ago at the age of 57. He had severe anemia, hemoglobin 4.8, hardly any reticulocytes, marrow, good cellularity, but paucity of erythroid precursors, just occasional pronormoblast, and everything else normal. Plasma cells were 6%. Serology for parvovirus B19, cytomegalovirus, Hep B, Hep C, HIV was all negative. Workup for systemic collagen vascular disease, negative. A CT scan of chest for thymoma, negative. Whole body PET for occult malignancy, negative. No obvious drug history. Conventional karyotyping and the FISH for MDS negative. Flow 4, T, large granular lymphocyte negative. Patient had an IgG lambda monoclonal gammopathy of 300 mg. There's no evidence of myeloma, and there's nothing to suspect amyloidosis, so hence this was taken as MGUS, the M band and the plasma cells of 6%. He received the standard treatment for his PRCA for 6 months with cyclosporine and steroids, which were tapered off. He had no response to this combination. He then received rituximab 4 doses, usual 375 mg per meter square once a week, no response. He then got ATG with cyclosporine and steroid, no response. He received pulse cyclophosphamide therapy, 3 months, no response. And it had to be discontinued as it resulted into significant neutropenia. He was given bortezomib weekly for 8 doses, Altrambopag and danazol for 6 months, no response. A repeat marrow at this stage showed 1% increase in the plasma cells, and this time the clonality study showed that these were clonal plasma cells. Once again, karyotyping and FISH study for MDS negative. Patient remained transfusion dependent, became iron loaded, ferritin went up to over 3,500, and he received iron chelation. At this stage, he was given daratumumab, 16 mg per kg once a week. For the first time after 3 weeks without transfusion, his hemoglobin increased to 8. And then after 6 weeks and after 8 weeks, it increased to 9.5 and over 11. His reticulocyte peaked at 6 weeks and became 3.2%. After 8 doses, DARA was reduced to once in 2 weeks for the next 8 doses like we do for myeloma. After 4 months, his hemoglobin was 12.5 and the ferritin by that time had come down to 120, and of course he was on continuous iron chelation. At this stage, the iron chelation was discontinued. DARA was reduced to once in a month and then once in 2 months, and at present he's getting DARA once in 3 months. And we don't know whether to stop it or continue. Patient so far has not relapsed with his PRCA, and he has no significant adverse effects to DARA. A repeat marrow at 1 year, after 1 year of DARA, showed normal cellular marrow, unremarkable trilineage hematopoiesis, adequate erythroid precursors, unchanged clonal plasma cells that had now increased to 10%, and his M band remains static at 350 mg per dl. A little bit of review of literature. MGUS with PRCA has been described earlier, and that's the reference. In a study from NIH, not NIH, NIH, 23.5% of idiopathic PRCA had M band, and 3 of these were successfully treated with bortezomib, lenalidomide, dexamethasone, same reference. Recently, successful treatment of PRCA following an APO-incompatible stem cell transplant with DARA has been published in 10 cases, and that should be of interest to our chief guest of the day, references. In present case, the MGUS was probably not etiologically related to PRCA and should be an incidental finding. DARA was not given to address the problem of MGUS, but it was used because besides targeting CD38 positive plasma cells, it is also an immunomodulator through its effect on CD38 positive T lymphocytes and CD38 positive B lymphocytes, including the tracks and the references. And now let's look at these references that I've been talking about. So you've got this MGUS associated with PRCA, British Journal of Hematology, 2016. DARA may be the most effective treatment for post-engraftment PRCA due to persistent anti-donor isohemagglutinins after a major ABO mismatch allotransplant published in Bone Marrow Transplant 2022. DARA for delayed red cell engraftment following allo New England Journal 2018. Successful treatment of refractive PRCA after allo with DARA, European Journal of Hematology 2020. DARA depletes CD38 positive immune regulatory cells, promotes T cell expansion, skews T cell repertoire in myeloma, Blood 2016. Pre-treatment CD38 positive regulatory T cell affect the durable responses to DARA in relapsed refractory myeloma hematologica 2020 and targeting CD38 in DARA in refractory SLE, New England Journal of Medicine 2020. So these are relevant references to this case that I showed you today. You can share your stories both in the form of quiz for the students as well as the case presentation. And you can have an opportunity to present your quiz and your case yourself from this forum. So if you have something, please share it with us and you will be our guest speaker on Sunday webinar, either to present the quiz or the case. Well, thank you from that angle. Now we come to the main part of our webinar, and that is our guest speaker, Dr. Rakhi Khan. Once again, she needs no introduction, a very senior personality in the field of hematopathology. She is Professor, Department of Pathology at JIPMA, Puducherry. She did her DM in hematopathology from AIIMS, Delhi, and MD Pathology from PGI, Chandigarh. Her areas of interest include hemostasis, hemoglobinopathies, flow cytometry, hematolymphoid biopsies, and lab quality management. She has been instrumental in setting up of specialized coagulation lab, hemolytic anemia lab, and the flow cytometry lab at JIPMA, and in the curriculum development and starting of specialized hematology courses. She is actively involved in teaching, learning, and research, and has been a guide for several trainees and PhD scholars. She is involved in several research projects, including 4 extramural funded multi-centric projects. She has over 100 publications in indexed peer-reviewed national and international journals, including 3 textbook chapters. She has contributed to ISHBT as executive committee member and its vice president. She founded the Pondicherry chapter of ISHBT. She also contributed to the growth of the society journal, the IJHBT, as its associate editor, and was awarded as the Best Reviewer of the Year award in 2019. She's going to lecture us today on myeloid neoplasms with striking erythroid hyperplasia, a case-based approach. So over to Professor Rakhi.
Thank you, sir, for those kind words of introduction. The first question, as usual, am I audible?
You're audible.
Okay. So I'll just share my screen and
We can't see us. Now we can see your screen. Perfect.
yeah, okay. So at the outset, I would like to thank Dr. Agarwal, sir, once again for giving me this opportunity and also the platform to share my experience on this topic today. So I will be speaking on myeloid neoplasms with striking erythroid hyperplasia, a case-based approach. Greetings from my institute, JIPMA. So can you identify this gentleman and what link does he have with this topic today? So if you have thought Guglielmo, you are right. Bone marrow neoplasms with erythroid predominance was first described by D. Guglielmo in 1917. He had described what is called D. Guglielmo syndrome, which actually is a group of diseases characterized by prominent proliferation of erythroid lineage with variable component of immature myeloid elements. And he also described D. Guglielmo's disease which is a rare aggressive neoplasm characterized by proliferation of immature cells committed solely to erythroid lineage with no increase in marrow myeloblast. And currently, this is what is known as pure erythroid leukemia. So what is meant by erythroid predominance, hyperplasia, striking erythroid hyperplasia in myeloid neoplasms? So by definition, prominent erythroid proliferation where erythroid elements comprise more than 50% of the total bone marrow cells. So how did this 50% come? Actually, this cutoff is arbitrary, but it has been so much widely entrenched in use that it has become accepted. And it can be seen in various hematopoietic stem cell neoplasms. This has also formed the basis of classification of some myeloid neoplasms in earlier schemes, this cutoff of 50%. So let us look at the journey of over a century of how these neoplasms with erythroid hyperplasia have found their place in the classification scheme of myeloid neoplasms. So as we discussed, it was in 1917 when de Guglielmo's initial description was given. In 1975, way long after, the UK MRC Working Party on Leukemia proposed erythroleukemia as a distinct subtype of AML, but it was not included in the initial FAB classification of 1976, but rather in 1985, FAB AML M6 category was mentioned. This was retained in 2001 WHO, where also a pure erythroid leukemia subtype appeared, and this both were retained in 2008 WHO. But the latest WHO classification that we are using, 2016, the WHO acute erythroid leukemia, erythroid myeloid type was removed, and only pure erythroid leukemia was retained. So sometimes this leads to confusion, but let us see what was the logic why this was done. So as just to reiterate, in 2008, we had erythroid myeloid type and PEL, but in 2016, it's only pure erythroid leukemia, which is in the acute erythroid leukemia category. So this entity, which has been removed, actually was defined by more than 50% bone marrow erythroid precursors and more than 20% myeloblast among non-erythroid cells, or it is non-erythroid blast count or NEBC. But now in the new classification, myeloblasts are always counted as percentage of marrow total nucleated cells. So this NEBC has been removed totally. So where do we put the former acute erythroid leukemia, erythroid myeloid type now? So now that this category is removed, blast percentage should always be enumerated of the total nucleated cells. And if the myeloblasts are more than 20%, it is AML. If it is less than 20%, it is MDS. For MDS, it was always part of total nucleated cell count. But this NEBC rule only applied to this erythroleukemia. So now since it is gone, so these cases of AML can fall in any of the categories depending on how they fit. So either it could be AML with myelodysplasia related changes, it could be therapy related AML or NOS, or if there is any recurrent genetic abnormality, then it falls in the recurrent cytogenetic abnormality. So what is the logic? Why was it done? Why favor TNC over NEBC? The first reason is disease biology and prognosis. It is seen that AML with erythroid predominance, that is the acute erythroleukemia, erythroid myeloid type, are biologically closer to high-grade myelodysplastic syndrome than they are to other types of AML. And there were studies supporting this observation. So this is one study which was published in 2012. And here they found that AML with erythroid predominance, exhibits clinical and molecular characteristics that differ from other types of AML. So I have just highlighted the conclusion that the clinical, cytogenetic, and molecular features of AML with erythroid predominance in the non-therapy related setting are much closer to those of high-grade MDS than they are to other types of AML. So disease biology-wise, they were more related to the MDS high-risk type. There are also been studies later where this is the group Spronson et al. Who have compared their a retrospective review that they have done to other published studies regarding this NEBC rule, the pros and cons they have compared, and they also favor removing the NEBC rule in WHO 2016 because they feel that MDS-EE stands for erythroid predominance, are not uniformly aggressive entity, but they are accurately diagnosed based on myeloblast percentage from total bone marrow cells. So this NEBC rule does not actually improve the risk stratification. So in this study, they have classified both by 2008 and 16 and compared it. So what I mean is there have been studies which have shown the close biological relationship between high-grade MDS and this AML with erythroid predominance. So that was number one. Number two, there are inherent flaws in counting in NEBC because of inter-observer variability, dysplasia, which often accompanies these erythroid proliferation. So estimating accurately the myeloblast can be a challenge. And a small difference in count can lead to a big difference in diagnosis. For example, if a marrow had 60% erythroid, 8% or more blast, like would make it acute erythroleukemia, erythroid myeloid type in the former classification, because 8 out of 40 cells would anyway become 20%. Whereas 7% blast would make it MDS excess blast 1. Suppose the blast count is 75% erythroid, 5% or more blast would entail it to become acute erythroleukemia, whereas 4% blast would make it MDS low risk. So a small difference in count, and there can be an observable variation where 1%, 2% count can be different, but it makes a big difference in the diagnosis. So these are the logic for which NEBC is gone now. It is only total nucleated cells of the marrow that the count is given. So which myeloid neoplasms show prominent erythroid proliferation? So let us understand it from the point of view on how effective is the erythroid proliferation. The first in the list is polycythemia vera, where we have effective and exuberant proliferation of erythroid. So this is a myeloproliferative neoplasm, so it is an effective proliferation. Erythroid proliferation can also be seen in other MDS MPN, though it is rare, but it can be seen in RARST. So this is one group where it is effective. The other chunk, MDS and AML, which we just discussed the nuances of the classification, these are characterized by ineffective erythropoiesis. And dyserythropoiesis is an important accompaniment. And then in the other spectrum, we have pure erythroid leukemia, which is de Guglielmo's disease. This actually is arrested erythropoiesis and immature erythroid blast predominant. So let us go through these cases and try to understand what are the important aspects of the erythroid proliferation in this. So this is case 1. It is a 56-year-old male. He's a known case of a person living with HIV on ART and a diabetic. He complains of easy fatigability, dyspnea on exertion, multiple joint pains for 1 month, and low-grade fever for 3 days. So this is his routine hemogram and biochemical investigations at diagnosis. So here we can see that there is bicytopenia, hemoglobin and TLC are low. but no atypical cells or blast in the periphery. Platelets are adequate, just adequate on counts. And the investigations, biochemical investigations show a raised LDH here, we can see. So with this, since there was a suspicion of hematolymphoid malignancy, bone marrow was done. This is the aspirate smear showing a nicely particulate bone marrow. And these are the loose cell trails here. So these are the cell trails, nicely cellular. And what we can see is numerous cells which are all having this good amount of basophilic light, basophilic cytoplasm with a very round nuclei, and some of them tend to be are seen to be binucleate, trinucleate. There are some mitotic figures, and in the background we are also seeing erythroid, which are maturing erythroid with dyserythropoiesis. Somehow myeloid seems to be very less here, and let's go to a little higher magnification. So these are the cells which I was talking about. They are having a round, nucleus. Nucleolus is not very prominent in this, but they were seen, and some of the cytoplasm of some of the cells had vacuolization. One more such picture showing again the multinucleation, and now the erythroid character of these cells becomes more apparent on morphology. With this kind of basophilic cytoplasm and rounded nuclei, you think of erythroid blast. So now it is better in this oil immersion photomicrograph. We can also see some vacuolation. And SPP stain done on this showed that these blasts were all negative. A lot of mitotic figures can be seen. This is a control neutrophil here. And PS stain showed positivity, coarse granular as well as some block positivity in some of these blasts. This is another one showing this PS positivity. So with this morphology, we thought that this is a proliferation, or it is showing predominance of erythroid blast or pro-erythroblast. So our thought was along the lines of pure erythroid leukemia. We also did a pearl stain which was loaded, and there were no ring sideroblasts in the bone marrow. So what is pure erythroid leukemia definition or criteria? There should be more than 80% of bone marrow cells which are of erythroid lineage with more than or equal to 30% pro-erythroblast and no significant myeloblast component. So our case fitted with this, and this was the diagnosis that we considered. Flow cytometry sample had also been sent, and that showed predominantly cells in the debris region corresponding to the erythroid cells, and actually blast window, the cells only comprised 1.4%. And these erythroid lineage cells, there was some HLA-DR positivity, but they were negative for all the lineage markers, but showed positivity for 235A and also positivity for CD117. So with this, we did give a diagnosis of pure erythroid leukemia, and we're eagerly waiting for the tryphin biopsy, and that showed a morphology like this. So you can see it's a very cellular tryphin biopsy showing almost near total infiltration by these immature looking cells, and this is close to the bony trabeculae. Now normally the erythroid are away from the trabeculae, but myeloid cells tend to be here. So what are these blasts? And this is in the spaces which is in the intertrabecular spaces, we can still see this big cells which are now showing some evidence of erythroid maturation, because we can see this maturing erythroid elements inside. And here and there some megakaryocytes showing some lobe separation and dyspoiesis in the form of lobe separation. Again, profusion of these cells which are immature, so blast. So to confirm their lineage, we did CD34, which was negative in these cells. E-cadherin was positive, nicely highlighting membrane positivity in these cells. And it was also positive in the paratrabecular region, confirming that they were blast of erythroid lineage. And CD117 was also positive in this blast. So sometimes it is difficult to distinguish myeloblast from erythroblast in the refined sections, but generally erythroblasts show a linear nucleolus. Their nucleolus is more prominent in the biopsy section. And if you see it along with erythroid maturing elements, that is favors erythroid blast. But in this case, it was more of sheets of this blast. So definitely immunohistochemistry was essential. And MPO was negative. It only highlighted these are the residual myeloid cells, myelocytes and all, which are there in the marrow. In the meantime, cytogenetics report had come, and that showed complex karyotype with loss of 7q in this patient. So we had some follow-up. The patient underwent post-induction with AZA and venetoclax, and his post-induction day 28 marrow also showed persistence of these pro-erythroblasts. So it was not in remission. Again, a reinduction, patient was not in remission, and he died in a hospital within 4 months of first diagnosis. So what are these distinct features of this pure erythroid leukemia? So this is a study published in 2017, which says that the uniqueness of morphological features of pure erythroid leukemia in myeloid neoplasm with erythroid predominance. A reassessment using revised WHO classification. So what are the unique features of this neoplasm? So in this study, they have used this 2016 criteria, and they have reclassified 97 of their myeloid neoplasms with erythroid predominance, and they have classified it into these groups. They had 8 patients of pure erythroid leukemia, in AML NOS 19, in AML myelodysplasia related changes 30, and in MDS 40 patients fell. 2 they could not classify. And among this, by multivariate analysis, the independent predictors of death, that is in myeloid neoplasms with erythroid predominance, they found that morphologic features of pure erythroid leukemia, very poor cytogenetic risk, hypoalbuminemia less than 3.7 gram per DL, and high serum LDH were independent predictors of death. So PEL had a very aggressive course and was uniformly associated as an independent predictor of death compared to non-PEL cases. So that was about PEL. Now going on to the case 2, this was a 31-year-old lady with easy fatigability for 20 days, and she had an outside report of AML, but no further details were given. And with that, repeat bone marrow was done. Her counts showed pancytopenia, and no atypical cells in the initial PS. This is the bone marrow PS, which showed pancytopenia, but an occasional blast was also seen in the peripheral smear. Now, marrow aspirate was again nicely particulate and cellular. These are the loose cell trails, and again we can see a lot of erythroid cells which are sticking here. So let us go to a slightly higher par and see. We can see the profusion of erythroid elements here, but lo and behold, there are some other cells also which raise the eyebrow that what are these cells. So now we can see that there are numerous erythroid, but at the same time there are blasts of non-erythroid lineage there, which need to be discerned from erythroid blast. So morphologically, you see this blast has less basophilic cytoplasm compared to the erythroid blast, and the nucleus is not so round as this and less clumpy chromatin. And here you can see a very prominent nucleolus. So this is morphologically a myeloblast. And when we looked at the imprint, actually there were numerous of these myeloid blasts or myeloblasts, which were very intimately admixed with the erythroid. So compared to the aspirate, the imprint had clusters of myeloblast, and even some of them showed orods. Yes, here also. So we can see the erythroid adjacent. These are all erythroid, 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 but this is a myeloblast. And SPP and PS was done. PS was negative. SPP was positive in the blast and even highlighted the OR rods. So this was a little dilemma because the blast count was coming 15%, but there were OR rods and there were clusters in the Trifine imprint. So we signed out as favoring acute myeloid leukemia over MDS EB2, and that report on biopsy and flow cytometry would follow. Flow cytometry was again from the aspirate sample, probably some dilution or had more erythroid elements. So the blast count was still less, 10.7%, a lot of cells in the erythroid debris region. And these blasts were of myeloid lineage. So in spite of the lower blast count, here we just said that they were blasts of myeloid phenotype. And we suggested that it is acute myeloid leukemia with erythroid hyperplasia, of course, with a note that biopsy report would refer to the biopsy report. So this was the biopsy, again, very cellular and a lot of immature cells, as we can see. Again, we can make out that there is some evidence of erythroid maturation. So here we can see the erythroid and the clusters of immature cells here. So again, we need to do IHC to ascertain the lineage. And this was CD34, which showed, actually sometimes CD34 doesn't come very strongly in the biopsy, even in cases which are positive on flow cytometry. We get this partial membrane or weak staining, and that is how it was there in this case. But 117 was nicely positive in clusters of these cells. These were in clusters, and MPO was also positive. The strong MPO positivity with some granularity refers to the myeloid maturing cells, but these ones are in the clusters, these are the blasts. And E-cadherin was restricted to few clusters. So they were both erythroid and myeloid, but as we had noticed in the imprint, the biopsy also showed a lot of myeloid blast. Cytogenetics showed a normal karyotype, and NPM and FLT3 were not detected. So this patient underwent a post-induction marrow, which was not in remission, but after that, the patient went into remission and is on follow-up. So let us discuss a little about AML with erythroid predominance. This is a study where a re-evaluation of erythroid predominance in AML has been done using the 2016 criteria. And this was a large study over 7 centers, and the patients enrolled were from 2008 to 16, and 146 cases of AML with erythroid hyperplasia were included. And they have also compared with some controls of AML without erythroid hyperplasia. So the authors have subgrouped the AML into different categories, as already shown in one of the previous studies. But what was interesting finding in this study is that among the erythroid predominant AML, there was more of AML myelodysplasia related changes, which compared to controls. So 62% among the erythroid predominant, as against controls 32%, which was statistically significant. And recurrent genetic abnormalities were less in erythroid predominant group compared to non-erythroid predominant, which was again significant. So what is important is that in the AMLs with erythroid predominance, more of the cases fit in the myelodysplasia related changes, and there are less cases with recurrent genetic abnormality. And among the molecular data, what the authors found was that there was less incidence of NPM mutation, FLT3 and RAS pathway mutations in erythroid predominance compared to controls. And it was statistically significant for the RAS pathway and the FLT3. So less of these mutations, but more of TP53. So here you can see 44% among the erythroid predominant AML carried P53 mutations. And In a univariate analysis, this erythroid hyperplasia has no impact in overall survival, but in multivariate analysis, the variable which was associated with survival was the cytogenetic risk category. So this was about their study on AML with erythroid predominance. So what are the important discussion points is that absence of favorable recurrent genetic abnormalities suggests that these alterations occur in hematopoietic stem cells, which are more committed to myeloid differentiation. And they did observe 2 cases of AML erythroid predominance with inversion 3 and 1 with the translocation 6-9, which are associated with morphologic dysplasia and unfavorable prognosis. So the biology of erythroid proliferation in AML could be any of these, either a reactive phenomena or due to metabolic deficiency or due to I'm sorry for this bad cough I have, or due to some paraneoplastic phenomena, or it could be part of the neoplastic clone, which is supported by the observation of frequent erythroid lineage dysplasia, but which was seen in 43% of their cases. So with this, we move on to case 3 and case 4, which are related. Case 3, this was a 60-year-old lady with easy fatigability and anasarca for 3 months. A hemogram showed pancytopenia with high MCV. So she had received parenteral vitamin B12 supplements for 3 months with no improvement. So a marrow was again done for MDS. She had a previous marrow also done, which I'll show later. And PS, yes, it did show pancytopenia, but there were also macrovalocytes, some teardrop cells. So that was the reason that she had been given a diagnosis of megaloblastic anemia. So this is the current bone marrow, which was nicely cellular. And as the theme goes, there are a lot of erythroids here, but we'll see it in a slightly higher power. We can see this erythroid, this again, multinucleate erythroid, lot of erythroid, but again, there are cells which are non-erythroid lineage, even at this power. So zooming on to them, yes, we have our culprits here, the myeloblast which are hanging around in the marrow, which have no business to be increased in a megaloblastic anemia. And in imprint smear also, we are seeing this blast here. And when we see the megakaryocytes, they are hypolobed megakaryocytes, which is again not a feature of megaloblastic anemia. This is a myeloblast, and another picture showing a lot of erythroid cells, but also myeloblast. These were negative for SPB, so for PS, but were positive for SPB. So this was a cellular marrow, and it showed 16% blast with megaloblastic erythroid hyperplasia and dyspoiesis. So we give a diagnosis of MDS EB2 and advise cytogenetics molecular study. Flow cytometry also showed 13.36% blast of myeloid phenotype. In the meantime, the Triphine biopsy was there, again cellular like the previous ones, and CD34, again, it was very weak, almost negligible. So this is CD34 staining the controls. Cells are actually not positive, but 117 did stain some of these cells here and there, we can see. And E-cadherin was much more. So compared to the previous one where we also had low blast, there the Triphine showed a lot of myeloid blast and less erythroid, but here still we have a lot of erythroid blasts, but definitely myeloid blasts are also increased as seen in the aspirate flow and also in CD117. MPO stained the residual myeloid cells, and this was megakaryocytes highlighted by CD61. So at this point, it was MDS RAB2. Now we looked at the previous bone marrow, which had been done 2 months back, and it was suggestive of partially treated megaloblastic anemia because the patient had still been receiving B12 folate. But at that time also there was a suspicion. So the diagnosing pathologist had advised to continue hematinics and repeat bone marrow with cytogenetics if there was no response. So the previous marrow, yes, lot of erythroid, but if we look carefully, even here there are some cells which rouse the suspicion of blast wing there. So there is increased, there are blast of non-erythroid lineage. So here you can see, this is the previous biopsy, again, hypolo megakaryocytes, these three, this four, these are all erythroid, but this is not erythroid. This is a myeloblast. And again, another field, this is a highly dyspoetic erythroid, but here this cell is a myeloblast. This is a erythroid. So this is another case slightly related in the theme of the disease. This was 65-year-old male who had complaints of intermittent breathlessness, middle edema for 6 months. He's a known case of myocardial infarction on antiplatelets. And on examination, there was anemia, no organomegaly. Lab findings, there was anemia, platelets and TLC were more or less maintained, low normal TLC. Biochemical tests, there are derangements, you can spot it, we can correlate it later. So just note the values of these. So PS, yes, it showed anemia, there are some macrocytic cells. Bone marrow aspirate again was cellular particulate, and these are the trails. Megakaryocytes were more or less normal in morphology, no dyspoiesis, and a lot of erythroid elements. But unlike the previous ones, here we are seeing more of maturing erythroid elements. But if you carefully note the erythroid here, they seem to have a fraying of the cytoplasmic margins, and some persistent basophilia is there in these. These are frayed margins. And further on, if you see, there is vacuolation in this erythroid. This is almost empty looking. So what is happening here, that these erythroid are looking vacuolated, but there are good number of erythroid. In fact, there's erythroid hyperplasia, but there's a normoblastic hyperplasia, but this erythroid are showing some subtle dyspoiesis, like you can see here. Other lineages were more or less normal. So we looked at the pearls, it was loaded with iron, but if you move, when we move away from the particles to the cell trails, we could make out in low power that there are numerous of these ring sideroblasts. And this ring sideroblasts were seen in various stages of erythroid maturation, in the early as well as in the late normoblast. Bone marrow biopsy showed it was very cellular, and in contrast to the previous cases, here we see that it's mainly the formed erythroid. So we are seeing a lot of erythroid hyperplasia, which is evident. But when there is more of proerythroblast, it just looks like a leukemia in the biopsy section. So here we can see there is erythroid hyperplasia. These little vesicular appearing ones are proerythroblast or the early precursors. Okay, so this was the erythroid lineage. Others were more or less normal. CD34, there was no increase. So finally, we call this myelodysplastic syndrome, single lineage dysplasia with ring sideroblast. So the point to highlight here is erythroid predominance in MDS can be seen in about 15% of MDS, and it is heterogeneous. So as I'm saying, MDS-E, erythroid is predominant, is heterogeneous and includes both indolent cases with low blast count as well as aggressive MDS with variably increased myeloblast. So as we have already discussed, the blast should always be expressed as total nucleated cells, and karyotype is a very important risk determinant. So now coming to some diagnostic pitfalls and reactive mimics. Now, we have seen that many times we can have reactive erythroid proliferations. So how to distinguish? And they pose challenges when there is megaloblastic change, dyserythropoiesis, and left shift. Sometimes even reactive proliferations can show more of proerythroblast. This is an example, recent case of post-chemotherapy marrow where they were just clusters of proerythroblast. So the clinical context becomes very important. So let us look at some morphologic clues to distinguish a pure erythroid leukemia from a reactive left shift. So as I have already shown case 1, in PEL, these proerythroblasts grow in diffuse sheets. And they tend to be smaller, contain more dispersed chromatin, and fewer and more prominent nucleoli, as well as cytoplasm, which is frequently vacuolated. But these are very soft pointers. It can even be seen in reactive. But importantly, reactive shift is often single cells or small clusters which are intermingled with other marrow elements. So this diffuse shift is what I find more important. And in general, the erythroid proliferations in myeloid neoplasms are usually haphazard with poor formation of discrete erythroid islands, whereas the marrow architecture is usually maintained in reactive conditions. So reactive you'll get nice erythroid colonies, but in case of this neoplasms, they tend to be haphazard. So that is an important consideration. So what about IHC? Is there any robust IHC which can help? While I was reading for this topic, I came across this nice article published in Journal of Hematopathology, where P53 immunohistochemistry has been shown to discriminate between pure erythroid leukemia and reactive erythroid hyperplasia. So they said that uniform strong P53 is unique to PEL. And these are pictures from their study. If you see, the lower panel in both these sides are PEL, whereas these are reactive. The first top one is megaloblastic anemia as per their study, and this is another reactive case. And when they do P53 IHC on the trephines, they found that this pure erythroid leukemia shows strong uniform positivity, which is not seen in other reactive conditions. So to test the hypothesis, even I tried putting P53 in our case, and this is our first case, which was pure erythroid leukemia, and look at the intensity. It was very strongly positive, P53 in the first case, pure erythroid leukemia. And I also put it up in the MDS excisplast and the ring sideroblast case, which was just a few cells here and there scattered. This didn't have so many proerythroblasts, more of mature erythroid. I didn't put it in the AML case because that had in the trephine more of myeloid blasts. So this is how the intensity. So we also tried putting it up in some of our recent reactive erythroid hyperplasia cases. So this was a case of dual deficiency anemia. This was IHA. And this is the same post-chemotherapy case which showed more of proerythroblasts. So it was a hypocellular marrow, but there were pockets of cellularity showing proerythroblasts. So all of these were negative. So indeed, it seems to be a robust marker which can be easily adopted as a help when there is a confusion. So to summarize, the take-home message is that a multi-parameter approach is essential. A good quality bone marrow aspirate smear or imprint in case of dry tap, because there is no substitute to doing a morphologic evaluation. Then carefully note the erythroid lineage, number one, proportion, maturation, and dysplasia. And myeloblast, if discernible, should be distinguished from pronormoblast and counted separately. Pronormoblasts are enumerated with erythroid. They are separately enumerated only if there is a diagnosis of PEL. And biopsy is important to distinguish from reactive proliferation. Ancillary test as required. But last but not least, clinical context. So to drive home this point, let me show you one case without a clinical context, and you think what would be your diagnosis. So this is case 5. It is a biopsy section. So can you make a diagnosis? It is very difficult. This is nicely showing a lot of erythroid proliferation. Even at this power, we can see so many erythroid islands. But there's also a good deal of megakaryocytes. They're actually in clusters. There are myeloid in between. A little higher power showing this erythroid proliferation. But actually, this was a case where even the megakaryocytes are kind of pleomorphic. This has bulbous nuclei. So if I give you this context that it is a 54-year-old with left upper quadrant abdominal pain, moderate splenomegaly, and this is the hemogram finding of hemoglobin 17.4, PCV 58.9, then it is easy to correlate and make it polycythemia. So if otherwise we see a polycythemia vera, I mean, here the erythroid proliferation actually is more of erythroid islands, which are formed elements. And there is no criteria of the extent of erythroid in polycythemia. The criteria is basically panmyelosis and megakaryocyte morphology. So erythroid cutoff is not there. Then another case. This is a 29-year-old male with easy fatigability. So here we can see these are the erythroid, but if you carefully notice, these are all opened up sieve-like chromatin. Okay, and no increase in myeloblast. So the PS showed hypersegmented polys. There were some giant metamyelos also, and in some of the fields we see more of proerythroblast. With this, it is easy to say megaloblastic anemia, but be careful of megaloblastic anemia, neither to overdiagnose nor to underdiagnose it, because dyserythropoiesis can be part of megaloblastic anemia and megaloblastic change can be part of dyserythropoiesis. So it's always good to look at the megaloblastic change, not in the proerythroblast, but also in the more maturing or the hemoglobinized red cells, because that is very useful. And look at other features of in the other series of cells as well. So with this, I come to the end of this talk, and we can take up further questions.
Thank you so much, Professor Raki, for that beautiful presentation and crystal clear differences in various aspects of this problem. We'll give you rest for 2 minutes, during which you will just answer the quiz that we had put up to the guys, and then we'll come back to you for the question and answer session.
Thank you, sir.
Okay, can you see my screen?
Yes, sir.
Okay. So today's quiz, you were shown a picture in which there was a blank and you were asked to fill the blank and send your reply. That was the blank. You had DNA, RNA, proteins answered. Many of you could not answer. I'll just go through a little bit of teaching for the postgraduate students. So your terms, which many of you replied, transcript, transcriptome, and transcriptomics. And once again, many of you replied this. So it's important to know the differences between the three, because only the central one was the correct one. So what is transcript? So a gene is the coding entity of the genome. It has the power to form the protein. First, it is transcripted into messenger RNA, in which the non-coding DNA sequences are removed. So mRNA is our transcript. mRNA migrates from the nucleus to the cytoplasm at the ribosome. And by taking the help of the tRNA and rRNA, a protein is built from the messenger RNA. Thus, not the entire gene, but the transcript of it, the messenger RNA, can translate into an amino acid chain. So to define, transcript is the mRNA related to the gene. What is transcriptome? Depending upon the type of experiment, a total set of mRNA, sometimes all RNA, present in the sample is called transcriptome. So by studying the transcriptome, we are studying not only the gene expression, but it also includes the study of all forms of RNA. So cutting short, the definition is the transcriptome is all set of RNA, mRNA, tRNA, rRNA, and other non-coding RNA present in the cell. So that's the genome, and this is the transcriptome, DNA, RNA. And lastly, what is transcriptomics? So omics, genomics is the study of the gene, of the DNA, of the genome. Transcriptomics is the study of the messenger RNA or transcript and related technologies, and proteomics is the study of the protein related alterations in the technologies. So that's transcriptomics. So you got all these terms now: genome, RNA, protein, genomics, transcriptomics, proteomics. We received a lot of correct answers. First one we will tell you later on. From the second onwards, between 11:42 a.m. to 11:53 a.m., these 11 minutes, we got these answers. These are the correct ones in the order. So the second correct answer was from Dr. Preetam Singha Roy, Dr. Archit, Bandhari Pandey, Dr. Tushar Sehgal, Dr. Rakesh Shah, Dr. Rima Miria Ibrahim, Dr. Bilal Kaji, Dr. Ketan Modak, Dr. Deepak MB, Dr. Jyoti Sane, Dr. Akshaya Mandloi Goyal, Dr. Kunal Goyal, Dr. Ankur Ahuja, Dr. Babita Sodi, Dr. Mayat Marier Sher, and Dr. Pujita Reddy. So congratulations to all of you. Your answers were correct. The fastest finger first was Dr. Tejaswini Gudibande at 11:41. So congratulations to you. She's Senior Resident DNB Hematology, Majumdar Shah Medical Center, Narayana Health, Bangalore. So congratulations to you. Once again, to remind you, you can share if you have a quiz or a case presentation and use this platform to present it yourself. Our website is mhgindia.com, and you can have all the information about future and past webinars from mhgindia.com. Well, thank you. Now we come to the question and answer session, and we'll begin using the hand raise sign in order in which you put it up. And I remind the audience, please put up your questions in the QA box or the chat box, and I'm sure Dr. Rakhi will be pleased to answer them. Starting with Dr. Sanjeev.
Yeah, good afternoon, everyone. Good afternoon, Dr. Rakhi.
Good afternoon.
Thanks for the excellent and lucid presentation as always. It was a very nice learning experience. So my question is regarding the classification of pure erythroid leukemia based on the cytogenetics, like we do in all AML NOS, that once we have the cytogenetics report and we find that there is a complex cytogenetics or AML MRC defining cytogenetic finding like loss of chromosome 7, then we say it should be reclassified as AML MRC rather than AML NOS. So should we say that pure erythroid leukemia is an exception to that rule unless we find myeloblasts, or it should be considered like in case 1 which you presented? So thank you.
So thank you, Dr. Sanjeev, for an excellent question. And as always, it has some twist to it. So what I think is pure erythroid leukemia is one such where it still stays pure erythroid leukemia, because here we don't have the proliferation of myeloblasts. It's only erythroid cells which are arrested. So we keep it as pure erythroid leukemia, but yes, more often than not, it has complex cytogenetics. So it wouldn't go to AML, MRC, I believe.
Thank you. I think this point can be highlighted in the WHO book or somewhere, because it is an important thing to know.
Yes, it's actually very important, because earlier we have had cases where we would call it NOS at the outset, but when the cytogenetics comes, it goes into the myelodysplasia related changes. Yes.
Thank you.
Thank you.
Thank you, Dr. Tushar.
Good morning, sir. Good morning, ma'am. And thank you, ma'am, for taking us through the journey of the erythroid hyperplasia and myeloid neoplasms. My question is, ma'am, more of a comment and a description that it is easier for a pathologist actually to and more tempting for them to diagnose erythroid neoplasms. But yes, so we have to keep in mind also the reactive problems that we are facing in our Indian patients, especially in our patients that we see. They have taken a lot of treatment from outside before coming to the tertiary care centers. So more of reactive conditions and more of nutritional problems are associated with our Indian patients. for example, drug-induced erythroid hyperplasia, megaloblastic changes, HIV changes. So all these can cause dyserythropoietic changes, which are significant. So the young students and the hematopathologists, they have to keep in mind all these reactive conditions because they are quite often mimickers of leukemias, and we have to correlate with the clinical output also and the details also for a proper diagnosis. So that is the point, ma'am, I wanted to highlight. Thank you.
Yeah, thank you, Dr. Tushar. That point is very well taken. Yes, the reactive mimics and reactive conditions have to be considered, and the clinical context becomes very important. That is absolutely true.
And secondly, ma'am, I just wanted to add this, that you discuss about ring sideroblast also. So it's good to know that ring sideroblasts are seen in a lot of reactive conditions also, like patients on AKT, anti-COX treatment, and alcoholism, copper deficiency, zinc excess. So it's important for us as a hematopathologist and the students also to learn about these reactive conditions also, and not straight away jump to the malignant conditions.
Yes, that is true. So any like say dyspoiesis or dyserythropoiesis doesn't make it MDS. So it can be an accompaniment of reactive conditions. So that point is well taken. Thank you for highlighting it. Yes.
Thank you, ma'am.
I will just like to add something from the clinical angle. A clinician becomes a sort of link between the patient and the pathologist. And in past, we used to have reports from our hematopathologist writing a sentence, please look for myelodysplastic syndrome. And you know, the patient does all this Googling business. So he will go to the net and see what is myelodysplastic syndrome and come running that I have a cancer. You didn't tell me that. We had to plead to our hematopathologist not to put the word that please search for myelodysplastic syndrome, because as Tushar said, and as Rakhi also said, when you have hundreds of reactive changes which look like dysplastic changes but not MDS, there is one MDS. So you are quite right, in India, this nutritional problem, drug-induced viruses, there are so many that even to indicate that word that please look for myelodysplastic syndrome, the patient gets very upset that he was not told that he has a malignancy or there may be a malignancy. So this is very, very important, because what has been communicated to the patient based on the report, his psyche becomes very important. Thank you. Dr. Sindhura.
Thank you, sir. Thank you, ma'am, for an excellent, very crisp presentation. So I have a couple of questions, mainly on the percentage of blasts calculation. I noticed that you have used flow cytometry also to correlate the blast percentage. We generally don't use flow blast percentage for the for classification of whether it is MDS, EB2 or AML. Do you use it in your institute to differentiate MDS, EB2 versus AML, like even the PL?
Yeah, so actually blast percentage, whatever the criteria are all on morphology. It is bone marrow blast percentage, which is on morphology. So that was just to show that had a good deal of erythroid, and blasts were less than 20% in those cases. But we don't use the flow blast percentage. And often the sample is diluted because morphology, they might have done in the first pool, but when they send the sample in a tube for flow cytometry, there's dilution. So that is not taken as the criteria. I mean, yes, the percentage cutoff is not based on flow.
Yes, ma'am. Yes, ma'am. Yeah. So precisely what we do. And to follow up with that same question, when the sample, the bone marrow aspirate sample for morphology is also hemodilute, would you suggest that we do blast percentage counting on the bone marrow biopsy using the IHC markers, like say E-Caterin or 34 and 117 combination, and use that? Because sometimes the aspirate would be so diluted, we are almost sure that it is still PL, but because of the hemodilution, the blast percentage does not meet the diagnostic criteria.
Actually, first look at the imprint. Sometimes imprint may still be better, especially if you're it's a dry tap or something. But even if the imprint is also poor, then we generally hold it because we can't give and we wait for the biopsy. Then when the biopsy comes, it is not easy to count blast on the biopsy. Rather, if you're seeing them in sheets or so, mention it as such and give. But giving an accurate count on biopsy is very difficult. I generally don't do it. But I mention it that it is seen in cluster sheets, the pattern wise. And we have seen this happening in cases of APMF.
Yes. Yes.
Sometimes actually technically poor aspirate also happens, but there the imprint is okay.
Yes, ma'am. Just a few other comments. With the new fifth edition of WHO also having the same diagnostic criteria as the 2016 criteria for the diagnosis of PEL. That's a relief for most of us. And second thing is to just an added comment to Sanjeev sir's question on whether whether we should call it as AML with myelodysplasia related changes. With the present WHO, the fifth edition says that the diagnosis of pure erythroid leukemia trumps the AML with the myelodysplasia related changes. So even if it is the cytogenetics are present, which say that myelodysplasia related cytogenetics are still present, even then the acute erythroid leukemia diagnosis holds rather than making it as AML MRC. And as you showed the TP53 IHC stain, especially with the biallelic TP53 abnormalities, even we find it difficult even when there is MDS EB2 with biallelic TP53 deletion. Even they show reduced TP53 expression on IHC. So generally doesn't really help us to differentiate between AML EB2 versus same acute, pure erythroid leukemia, especially when there is biallelic TP53 deletions. Both are aggressive. So those are the 2 points I wanted to make. Thank you, ma'am. Thank you for a very nice presentation. Thank you, sir.
Thank you, Dr. Silvera. We'll take one question from the question box. Dr. Jyoti Sane wants to know, when the clinician is strongly suspecting MDS based on the clinical picture, how do you proceed when the erythroid series is showing minimal dysplasia or no dysplasia in the other lineage? Should you suggest cytogenetics and NGS, etc. should be done?
Yeah, I think, sir, cytogenetics is very important, but like I would also say that look carefully for ring sideroblast and all. These all can be, you have to suspect, and like we make it a practice in any suspected case of MDS. There, the dysplasia is not very florid. Dyserythropoiesis can be very subtle, like the case I showed you. It just had erythroid, some vacuolation and fraying of margins. So like that. But apart from that, I would also say that cytogenetics becomes an important aspect here. But we can't give it based on morphology. That is true.
Right. So again, I may just add, Dr. Jyoti, that clinically, of course, we do have an advantage of the history, the examination, sometimes the therapeutic trials, and a long story which might have been going on for some time. And then all your morphological changes on aspiration and biopsy. But karyotyping and the fish study become extremely important. If that data is not available, then we are always uncomfortable. Just a word of caution about this NGS business. I don't think we exclude or confirm the diagnosis of MDS based on NGS. So there can be changes which are age-related, and there can be changes which are MDS-related, but not specific to MDS. So it's the karyotyping and the fish which helps and not the NGS. NGS becomes important for fine-tuning and the changes in the treatment in any myeloid malignancy, including NDS. So that's just my addition. Dr. Amrita.
Good afternoon, everyone. Thank you, sir. And wonderful information by Dr. Rakhi. I really appreciated the way she has covered such a challenging diagnosis. I have few questions and few comments also to make. And I appreciate like the way the panelists have raised these questions, which are actually important in our day-to-day workup. My question to Dr. Rakhi is, one is like, many a times we get a marrow which is not truly representative. And I would like to ask her, like, how justified she thinks is the criteria of this more than 80% blast as a cutoff to label a case of PEL based on its prognostic implications, since it's a very serious diagnosis. So what does she think, like, how justified it is?
Yeah, you have actually hit the nail on the head that often we don't get good aspirate, and we have to live life with whatever we have. So having said that, there is a note mentioned in WHO that even in, with less than 80% erythroid lineage, you can still make a diagnosis of PEL if there is a sheet-like proliferation of these erythroid blasts in the biopsy. So due to some reason, dilution or this, like, you know, many of the cutoffs are by usage over time, but yes, that 80% is there, but still it can be if the biopsy shows a pattern where it is sheets of erythroid and you have the morphology of pro-erythroblast.
Yes. So this is a message for our, DNB students, DM students and fellows, that they should not blindly follow this cutoff of 80%. So because recently we faced a case where this was the situation, and truly speaking, it's like a sharing of the experience that the moment we saw, they look like, plasmacytoid. So we thought maybe it's a plasma cell, neoplasm. But when we actually did the stains, the pass, the flow cytometry, because biopsy takes usually 2 days. So, and clinicians are after, they are very, very, restless and they want to know the diagnosis. And then, of course, the final diagnosis of erythroid leukemia was made. But this is again, based on morphology, one can never be sure in first go that what we are actually looking at, they belong to, pro-erythros, because sometimes it very closely mimics plasma cell morphology. And I also understand, as far as this reactive thing is concerned, many a times it's basically a proactive approach to find out the history from the patients. They don't tell the clear history in one go. They simply say about certain things because in a tertiary care center, they reach after spending, time, wasting money at different places. And when they are sort of helpless, then they land up with their big file and, a hope of getting a final diagnosis and a management. But unfortunately, it's too late by the time. So that was like a point to share. I have one more question to ask you. Like, what exactly should be the strategy of lab workup in a suspected case of myeloid malignancy, because there is always a challenge in arriving at a final diagnosis, and sometimes that financial constraints are there. So what will you suggest if such a case comes? What should be the strategy? Because not every time patient has enough money for special stains or like say flow cytometry or cytogenetics. So as minimum, what should be like, even if we talk about T53 on a bone marrow biopsy, sometimes patient doesn't even have that much of money. But can you just make a comment on the strategy which can help?
I think morphology stays, but we do need ancillary studies. There is no, escape from that, because you want to be sure once the diagnosis is made, it is stamped. So like even in the previous case that you just said, when you have a lower percentage, I would still be comfortable if I had done an additional P53 or, had some backup to say, yes, cytogenetics report has come in. So I'm comfortable. So that way I feel that it is important that the ancillary test or flow cytometry is done, because it is, after all, you are giving a diagnosis of a malignancy. Based on that, rest everything follows. So we can't compromise at the giving the, doing the necessary tests. That's my thought.
I think flow will be more of importance in terms of exclusion rather than, pointing towards
in
the
these,
diagnosis.
when you have erythroid, it is not necessary in these, like you can still do it on the trephine biopsy, you can do
Right. Yeah. Thank you so much. Thank you.
Thank you. I want to add one thing here. Treatment of myeloid malignancies is so expensive that any money spent on the diagnosis is in front of that an extremely small amount. As we were chatting before the session started, accurate diagnosis is so important to prognosticate the case and save the patient from unnecessary expenses of treating a wrong disease. So in hematopathology, it's the onus is of course on the clinician, not on you all, that they must not request you to cut down any investigations. It's not worth it, because even 1 month of wrong treatment and the patient is going to spend so much money, probably 1/10 of that you would have given an accurate diagnosis. Okay, Dr. Akshaya.
Thank you, sir. And thank you, ma'am, for the very practical talk, especially the TP53 part. Ma'am, my question to you is how to comment on complete morphological remission in a post-therapy case of pure erythroid leukemia?
Actually, the same criteria usually doesn't hold, is what I would what we saw in this case, which I showed, was that there is still persistence of pro-erythroblast. But normally in a leukemia, the morphological remission criteria would be like less than 5% blast. So I am not very sure if I have read anywhere the exact percentage of blast being there, but I believe it should be not having pro-erythro. You can't really have not have 5%. So I guess it is the same persistence of pro-erythroblast being majority of cells, which makes it not in remission. And if there are other lineages which have come up, the myeloid and MECs are regenerating, and there is erythroid maturation, then I would say it is in remission.
If trilineage hematopoiesis is there, but still erythroid are predominant population there, and pro-erythroblasts are around 5%, would we label it a morphological remission or a partial remission or something like that?
That is something, actually you're giving me food for thought, I would say, because it is a hypothetical situation. I have not seen many such cases. It would be also very difficult to pinpoint that, exactly count the pro-erythroblast among the erythroid. But yes, we have to do that. Among the erythroid, only count the pro-erythroblast. I have not read it anywhere that it should be 5% pro-erythroblast, and less than that to call it in remission. So if it is so, it is in remission. But maybe then the better word would be partial or whatever remission. So that is an important point which I will also try to look up, like what would be the remission criteria.
Can I add into it, ma'am?
Yeah, sure.
Ma'am, so if we do baseline IHC on the first sample of the patient, and we do E-cadherin on that, and we compare the level of E-cadherin on the remission marrow, would that help it?
Actually, her question is the percentage. Like she said, what I understood is that there is erythroid maturation. The pro-erythroblasts have reduced. But what is the cutoff to call that marrow is in remission versus not in remission?
So comparison of the first marrow and the...
Yeah, that would definitely be useful to say that there is maturation in the erythroid lineage compared to the baseline marrow. But to what extent would you take it as in remission and not in remission? Any other thoughts, if any, please share.
Can PAS can be helpful cytochemistry on the bone marrow aspiration? because if showing that coarse granular vacuolations, then it may be suggest that these are the dysplastic pro-erythroblast or the dysplasia, and patient is still having a disease instead of remission.
No, let's say like there is initially there were more than 30%. Now there are 10% pro-erythroblast post remission, and there are some with PS positivity, occasional ones.
Well, I think this appears to be a rare situation with no answer.
So I've, but I think what we understand is you have to compare it with the previous bone marrow and see whether erythroid maturation is there, because the main thing is there is arrested erythroid maturation in PEL, and once a marrow starts recovering, there is always maturation that has to be documented.
It's like, I think you will have to search for the answer finally. Looks to be a very rare situation. And Akshay has really brought out an issue which is not having an easy answer. We'll take up one more question from the audience. Dr. Bilal wants to know, apart from megakaryocyte clustering, which other megakaryocyte morphology is specific of primary myelofibrosis in a bone marrow trophine biopsy? Besides clustering, anything else?
Yeah, one important aspect in myelofibrosis is we also tend to see very hyperchromatic megakaryocytes. They are small, dyspoetic, nucleus is hyperchromatic. Often you see intrasinusoidal megakaryocytes, and also they can be in an abnormal location. Like normally megakaryocytes are in the intertrabecular region, but you can see them close to the bony trabeculae. These are other important features. And megakaryocytic proliferation can also be very florid.
Thank you. Dr. Tara Roshni.
Good afternoon. Ma'am, I just wanted to know the IHC that you use. You said E-cadherin for early erythroid precursors. Does glycophorin have a role, or is it only for the later precursors?
Yeah, actually, we have used glycophorin, but the problem is it stains the later precursors and also the red cells. So it's a kind of so much positivity that it confounds. And generally, the problem is distinguishing erythroid blast, pro-erythroblast from myeloblast. So in that regard, E-cadherin is the best, because their glycophorin doesn't have much discerning because of the much more staining that it.
One more thing is regarding the P53 use. We too used it recently to differentiate florid erythroid hyperplasia from a pure erythroid leukemia. The article says there's intensity, but is there any percentage cutoff, or can we count it as such, the P53?
Yeah, actually they have said the intensity which they have graded, and also the percentage.
Okay.
Both ways. The intensity they have graded as 0, 1, 2, 3 plus, and also the percentage. So generally most of the reactive conditions showed in whatever I had done a few cases around 10, it was less than 5%. This case showed like it was more than 30%. No, it was in fact more than that, 40, 50% like that staining.
Okay. Thank you.
Thank you, Dr. Tara. One more question from the audience. Dr. Kanan Ramamurthy wants to know, do you do flow in all cases of your MDS? And have you found it useful in cases where morphology failed?
Actually, routinely in all cases of MDS, we don't do it unless it is, suspected at the outset and they have sent a sample for flow. Generally, for AMLs, it is sent. For MDS, we don't do. We rely more on the morphology and advise cytogenetics.
Right. Dr. Kanan, we discussed this issue in a MDS meeting with international speaker. And they said clinical practice flow for MDS is not done. And as Dr. Rafi said, it's only from the angle of blasts. You don't make a diagnosis or rule out MDS based on flow. It's still a research tool. Okay. Dr. Ankur. Unmute yourself, Dr. Ankur. Unmute.
Good afternoon, sir. Good afternoon, ma'am. Excellent lecture, ma'am. As like a good teacher, you have already explained my one or two questions. Like I also read about P53, this thing I see. So I just wanted to ask your experience. You have already told me. and the percentage, as Dr. Tara ma'am has already mentioned it. Ma'am, what is this? Basically, have you experienced the P53 role in the flow cytometry also, so that we can get a?
We don't have it as a flow marker, Dr. Ankur. Whatever is like P53 is only on IHC or that.
Okay, ma'am.
Yeah.
Ma'am. And ma'am, likewise, we all have experienced the dilution aspects in the bone marrow. So blast counting is always, likewise, I also experienced in one of the case in which clinically I also found it, it looks to be a kind of a acute leukemia, erythroid leukemia, but despite of my counting on 2000 cells, the blast percentage was just 12 to 15%, and out of those things, only one or other order was seen in 2000 cells. But in biopsy, I could able to find the cluster of those blast or cells. But is there any? Can we attempt the counting on the biopsy by staining CD34 or CD71 or E-cadherin marker?
As I had already said, actually, I personally find it very difficult to count it on the biopsy, give an accurate count, because CD34 may or may not stain. It may not stain optimally. So in such a case, you can give it as like that many, whatever percentage of blast of myeloid phenotype, and however the biopsy shows clusters, and also correlate with the cytogenetics, whether it is AML-like or MDS like that also would be important.
Fortunately, the cytogenetics came normal in that case, and as such a cautionary note, I wrote in the report that MDS, though it is as per the saying MDS excess blast 2 is there, but clinically and in the biopsy, I could able to find the aggregates. Please closely follow up, and incidentally, after a month or so, it became a full-fledged pure erythroid leukemia. Thank you, ma'am.
Thank you, Dr. Ankur. Dr. Vidisha.
So thank you, ma'am, for the wonderful spectrum of cases that you've showed us today. My question is more of a practical case scenario in which we have these elderly patients coming to us with unexplained cytopenias, and on the bone marrow, you have basically a trilineage hematopoiesis, mild dyspoiesis. And so when is the point where we decide that we have to go ahead with we ask the clinician to go ahead with the cytogenetics and FISH? The serum B12 level is normal, the viral and the other causes of the cytopenias have been ruled out. So when is that clinical point where we decide that we can ask them to go ahead with the cytogenetics FISH? Because marrow samples for cytogenetics, they generally are stable for around 5 days maximum, what the lab says. So how do we wait for the biopsy? Do we wait for the IHCs, or we go ahead with those additional tests in the upfront only?
Actually, if the clinical suspicion of MDS is there based on persistent cytopenias and other causes being ruled out, then I think it is better to advise for cytogenetics. That is my, because what you are saying, what I understand is like causes of nutritional causes have been ruled out, or the patient has already been treated, and there is persistent cytopenias, which you are, but you are saying that there is not significant dysplasia on the marrow, morphologic dysplasia.
Yes.
So then it does become important to go for cytogenetics.
Like in the spectrum of cases, sorry ma'am, in the spectrum of cases where we've got the cytogenetics done, we generally find a normal karyotype. So then we have questioned that we went ahead with the test. And so anything in that scenario, ma'am?
Can you repeat?
So if I've done 50 cases in which I've sent the cytogenetics and FISH in unexplained cytopenias, and most of these times the MDS panel comes normal. So anything else that can explain these cytopenias?
Apart from that, one important thing that we encounter is, this splenomegaly leading to, hypersplenism and all. I hope those are ruled out, because sometimes.
Yes, ma'am. This is
that
basically
can also
elderly age group, ma'am.
Yes,
With unexplained cytopenias. So we end up with actually no diagnosis in the end, with a normal marrow, with normal cytogenetics, and then they just remain on supplements.
Okay. So
Dr. Vidisha, I think I'll help you out in this situation.
Yes, sir.
So this is a everyday problem that I've got a patient of pancytopenia. After all the workup, detailed history, examination, a number of people having seen them before you and have done therapeutic trials. Patient has a pancytopenia which has persisted. There are no nutritional deficiencies. There's no response to betel folic acid. Patient does not have heavy metal exposure or heavy metals have come normal. All the virus workup that you can do, parvovirus, CMV, EB virus, etc., all has come negative. As Dr. Rakhi said, you have ruled out hypersplenism. There is hardly any splenomegaly, including on sonography. And patient's morphology in peripheral blood and the bone marrow is inconclusive or it is nearly normal. Even the hypersplenism, the neutrophil to lymphocyte ratio persists. So you'll have more neutrophil than lymphocyte than in primary marrow diseases like MDS. So you've got 60-65% neutrophil, which are normal, 30-35% lymphocytes, which are normal. So even if there is a little splenomegaly, that could be a part of the bone marrow disease rather than hypersplenism. So you're left with finally an unexplained pancytopenia with little bit of hepatosplenomegaly or no organomegaly, and a primary marrow is the disease. Now, 50% of patients karyotyping will be normal. That's a standard book statement all over the world. And same thing you see over here. In fact, here you see even more. Forget 50%, 60, 70% karyotyping will be normal. Fish panel can be done from peripheral blood. So even if you haven't stored the marrow, you don't have any marrow left for the fish panel, you can do the fish panel from peripheral blood. It's expensive because each probe is going to charge you something. And if that fails, then here is the place for NGS. Because NGS will be abnormal in 95 to 98% of patients. So history, examination, a follow-up, the sonography, the portal hypertension workup, the therapeutic trials, all that is over. Karyotyping alone can never rule out MDS because it is normal in 50%, but you must always do it. Why not? It's much cheaper test than the fish and the NGS panel. And then the patient has to accept the expenditure on those two. As I said, the treatment of MDS is going to be many, many fold more expensive than the fish and the NGS. But karyotyping has to be done, and it is negative in 50% of patients in the best of the center.
Okay, sir. Thank you, sir.
Okay. So we have Dr. Chitra. Yeah.
Thank you, sir. And Dr. Rakhi, thank you for an excellent and very informative presentation. It was a pleasure to listen. My question is, in a patient with high hemoglobin, at what point in the hierarchy of tests will you consider doing a bone marrow vis-a-vis working out for ruling out secondary causes?
Okay, ma'am. I think we are talking about bone marrow for diagnosis of a polycythemia vera.
Yes, yes.
So yeah. So actually, one of the criteria is the morphology of panmyelosis in the bone marrow along with the megakaryocytic morphology. So that way, it is important to do. But of course, we have to rule out secondary causes like erythropoietin level has to be done. Then, of course, we have to look at the oxygen saturation and also do JAK2 mutation. Sometimes, even without that, we can easily diagnose without a marrow. But bone marrow is important to confirm the morphology and also look at the baseline reticulin fibrosis. So first do the test which can be done easily on the peripheral blood and rule out secondary cause. After that, go for it.
Thank you.
So again, I will have to add something.
Yes, sir.
No, because it's slightly different approach when you are from the clinical angle. So as Dr. Rakhi said, looking for the spleen, looking for the EPO are the first two tests. So if clinically spleen is not palpable, we go all out to see whether there is a subclinical splenomegaly. And the EPO level of a reliable lab is extremely important because, as she said, saturation, this, that. So high EPO causing polycythemia, low EPO causing polycythemia, two different categories altogether. So when there is a clear-cut case, JAK2 is positive, spleen is enlarged, EPO is low, you may or may not do the bone marrow. It's only from the angle of that is associated fibrosis, etc. there or not. Patient has polycythemia vera. But when the EPO is here and there, the spleen is not enlarged, or of course, a very small percentage of patients with the JAK2 is negative, then bone marrow biopsy becomes mandatory. And as JAK2 alone is not specific for polycythemia vera, it can happen in myelofibrosis, it can happen in thrombocythemia. So if my EPO is not very consistent with clinical diagnosis, or I have little bit WBC here, there, or platelet here, there, then I need bone marrow to differentiate with the type of MPN. So to know whether it is MPN and to know the type of MPN, bone marrow biopsy becomes indispensable. So if clinician is trying to, see where to do and where not to do, I think it's a mistake. You need to do it. Unless the EPO is extremely sky high, and you've got the things which Raki mentioned, oxygen saturation is low, this, that, you'll clearly know what is the cause of the secondary polycythemia. Then it's okay. But when you don't have a diagnosis or you have a diagnosis, you need to do it. It's a thought process on the front of clinician. There's some blockade that, can I avoid the bone marrow biopsy? Why do you want to avoid it? It's a small peripheral test in hematology. It is used like water. Why should you avoid it? For a lifelong diagnosis and a very expensive treatment again, drugs like Jakavi cost thousands and thousands per month. So why do you want to avoid it? Okay.
Thank you, sir.
Dr. Kunal Goel has a question. Can all reactive with anti-RC84, that is anti-human erythroleukemia cell line antigen, or any other antibody, can help in quantification or documenting remission?
Can you repeat the question, sir?
Can you open the question answer box?
Yes.
A top question. Just read it yourself.
Yeah. Can cell reactive with anti-RC84, anti-human erythroleukemia cell line antigen, or any other antibody help in quantification or documenting remission? Okay. So Dr. Kunal has said that I think it is in context to the question on remission criteria in pure erythroid leukemia. So he has suggested that quantifying this cell with the anti-human erythroleukemia cell line antigen. Actually, I don't know if it is widely available because I don't have any experience on that. So provided it stains, yes.
Never seen this kind of report.
Yeah,
anybody is doing it over here? Or anybody knows about it? The literature, Kunal of course knows, but he's not in our panel. All right, I think we'll move on. Is the Dr. Shashi now? Yeah.
Good afternoon, ma'am. And
those of you who have finished your question, if you don't have any more questions, please remove the raise hand sign. It is confusing.
Very good afternoon, ma'am. It's a very excellent lecture, and you are a very good teacher. You remind me of Mamsi's days. I have a very practical question. Like how to assign the blast percentage in the case of these cases when the peripheral blood also have numerous erythroid cells. Okay, so like the cases which have the numerous erythroid cell in the peripheral blood, the percentage of blast is calculated on the total leukocyte count, TLC.
Yes,
but the percentage of blast in the bone marrow is a TNC. So sometimes I acquire some cases where the percentage of blast in marrow, peripheral blood was 12%, but in the bone marrow, it was coming like 6%, 7%. So how to categorize these kind of cases? Is it excess blast 1 or excess blast 2?
Okay.
Because the treatment is going to be different in those cases.
Okay, again, a very interesting question. So in the peripheral blood, yes, the blast is out of the total. We don't include the red cells in the blast count. So what do we do is, if NRBCs are more than 10, we correct it. First thing is you correct the TLC, and then you give the blast percentage.
So but the TLC is corrected, but the percentage is blast is out of TLC, not the TNC in the peripheral blood.
Correct, that is correct.
Yeah.
In the marrow, the erythroid are also included. It is TNC. Yes. What the next thing that you said is that peripheral blast being more than marrow blast. I personally haven't encountered it very often, but if so,
I did 2 times, and my clinician was asked them alive how the marrow blast is less as compared to the peripheral blast?
Yeah, I think then it will become EB2 because excess blast 2 because it is OR. Bone marrow blast. See,
should we do the correction in the way of TNC in the peripheral blood also? That was my thinking. Because once we are doing the percentage of blast in the bone marrow in the TNC, but the percentage of blast in TLC, but the erythroid cells usually doesn't come in the peripheral blood, but this is cases which have the florid erythroid hyperplasia also, which have numerous cells in the peripheral blood. So these cases should be counted oblique TNC or TLC itself.
As of now, we calculate by default blast, we exclude the erythroid in the periphery, but what you're saying is right. The same corollary, if it holds, then the blast percentage would become lower in the peripheral blood.
Yes. So
but as of now, what we do is that we correct it and give it out of the percentage of the total leukocytes in the peripheral blood.
That is a thing.
Yeah, and if it comes more, then it upgrades it, because if you see the excess blast, it is bone marrow blast percentage 10 to 90, or the peripheral blood. So suppose you have got marrow blast percentage less than 10, but peripheral blast is like 12, 13, then I think it will come into excess blast 2 rather than 1.
One more thing, ma'am.
Can I just put one question?
Yeah.
Peripheral blood is a homogeneous material.
Yes.
Marrow can be patchy. So
Yeah.
if you really do bone marrow from 5 sides, you may get 5%, 7%, 10%, 12%. That was my understanding. So doesn't that happen that if you do marrow on 2 separate days from 2 sides, you get different figures? Because marrow does not always exactly tell you what is happening in the total marrow. And it can be associated fibrosis, difficult to aspirate. There can be so many issues. So if you got 12% blast in the peripheral blood, and I have seen this multiple times, that bone marrow has less blast than the peripheral blood. But then you will, I would go with peripheral blood. I've been doing that. Because marrow, I take it as that it can be patchy. It can vary every day from different sites.
Yes, sir.
Wrong or right, I don't know.
I agree with that, but I'm documenting the cases which have very nice marrow. And even I have seen the cases.
But it can be patchy.
Basically, if in the hematological disorders, the marrow is uniformly involved mostly. And when we have a very well spread marrows, and usually I get 90% very well spread marrow, that I'm lucky in that. And very good marrows are there. And when we count it uniformly, I have a cases of MDS. In that, the marrow blast percentage was less as compared to peripheral. Then I search in the WHO. There the cases reports are there, and they says the blast percentage more in the bone marrow, less in the bone marrow, more in the peripheral had the worst prognosis, and that is documented. So I don't know about the erythroid cells, but in the MDS it is documented. It is in the WHO also. So that has a significance in the prognostic way also. So I'm counting those, and because my clinician, even in the because we report a case like peripheral blood aspiration, biopsy, and flow, it goes in the one way. So we cannot differ the report in the one way. One person will report in all these things. Then he always inquire, you are the same person who was doing the peripheral blood, the bone marrow, then flow, how you are differing the things. I have to give the answer to the patients. So these are the general query which I have.
Okay. You have more questions, right? Just go ahead.
Thank you, sir. Actually, one question was there, which was already explained with the P53 and FLT3 and that NPM. So basically, I query one case which there, I was in the confusion of the AML or the MDS. So in the resource setting, we have to give whether I have to advise for FITS for MDS or AML translocation panel. But luckily, the patient went for the both. And it was MDS excess blast, but the FLT positivity is there. The clinician was very happy the FLT3 is coming. So do you have any experience how much percentage of FLT3 and all these things are coming positive in the cases, in these cases, so that we have to uniformly advise for these cases?
You mean in the cases of AML with erythroid predominance?
Yeah.
Yeah, generally these cases have less FLT3, what I read up in the articles, compared to AML without erythroid predominance. The cases of AML without erythroid predominance have more of FLT3 and NPN mutations, whereas those with erythroid predominance have more of P53 mutations. But I don't have experience in our center of percentage-wise. I couldn't.
FLT3 commonest is M4, M5.
Thank you.
This is M4, M5. They have leukocytosis. M4, M5 outnumber the other types. So FLT3 positive, but of course, nowadays all that is not important. FLT3 is FLT3. If you, whatever type of M1 to M7 you may have, that does not matter really. Okay. Dr. Amrita, you have a question?
So this is actually in response to Dr. Shashi's question, which is like, I would like to make a comment. Whenever we have, same center doing everything, like including peripheral blood morphology, and then same day we get a bone marrow in the afternoon, and then sample for flow cytometry, and the sample goes to molecular. So whenever we are generating a composite report, we can always mention as a, disclaimer that every test has its own capability of, commenting on the final impression. Like, we cannot assess blast percentage in a flow sample. That is something actually is not correct, because flow is not representing the quantitative, it is more of qualitative report. And then in the, morphological features, it is the bone marrow may not be representative. As you correctly said, it's a heterogeneous kind of distribution in many cases, where even if bone marrow is very satisfactory in terms of cellularity, but there may be a patchy distribution of abnormal cells, whether it is blast or it is plasma cells, or like we know it very well that not every time when we get a second marrow, there may be a different distribution of blasts. Sometimes they have to do a second marrow to just get a right diagnosis. So this is just a suggestion, like whenever we are releasing a same composite report, including all the investigations where there is a variability and every test is different, we can give a disclaimer so that clinicians don't doubt on our morphological findings and interpretations and final comment, and they can use their clinical judgment and reach to a final, diagnosis and treatment can be started.
Extremely well said. Thank you.
Thank you, sir. Thank you.
I don't see any other raise hand sign. Anybody wants to ask anything to Professor Aki? Okay. In the question box, there's some question lying for me. I will answer you directly, doctor. This is Rakhi's show today. Okay. So, Dr. Rakhi, thank you very much for being with us. A lovely talk, excellent question answer session. A difficult area in hematology, especially that question really which floored me, that how do you diagnose the remission in erythroid leukemia? It was fantastic. So thank you so much for being with us and educating all our listeners. Thanks to our sponsors, thanks to our event manager team, and thanks to all the faculty that is present here, and the large number of audience. We have today participation again from more than 20 countries. And I'm sure they have all benefited. Thank you so much. Have a wonderful Sunday. Bye-bye.
Thank you.
Thank you, sir. It was a pleasure for me. And once again, thank you for this nice discussion. Thank you to all the discussants. And I must thank you, sir, for organizing such events.
It has been wonderful because of you people. Thank you. Bye-bye.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am.
Thank you. Thank you, everyone.